reshape the bones in the skull. Here's a diagram of some various shapes in the skull and their corresponding names. The first one is scapocephaly, is if the sagittal suture fuses, and scapo meaning boat, thus it has kind of an oval boat shape. Trigonocephaly, the metopic suture is fused, trigono being triangle. Plagiocephaly, plagio means askewed or crooked. If one of the coronal or lambdoid sutures are fused, you get an asymmetric shape. Brachycephaly, brachy meaning square. If both sides of the coronal sutures are fused, you get a square-shaped skull. One differential diagnosis when you're looking at a skewed skull shape would be if it's craniosynostosis versus a deformational plagiocephaly. Deformational plagiocephaly is an asymmetric head shape due to external factors. So the cranial sutures are actually normal, but the skewed head shape comes from an external factor. Things that could cause this would be a restricted intrauterine environment where the infant skull is pressed asymmetrically in the uterus, prematurity, sleeping for extended periods of time in the same position, or a muscular torticollis where the neck muscles are tight and it's difficult for the baby to turn their head. And you can see in the picture, if the baby is sleeping on one side of their head for an extended period of time, it may cause the bones to shift a little bit and the head to be skewed. Now, a good clinical exam can clue you into whether it's a craniosynostosis or a deformational plagiocephaly. As in the picture shown, if you have a fused suture, you can see how the skull misshape is a different shape than if it was just a positioning type of force that was causing the asymmetry. Now, if it's just a deformational plagiocephaly, the sutures are normal, so the treatment is some helmet molding. And if you've ever seen the infants wearing the helmets, that's the point of this helmet, is to help those bones shift back into their regular position. The next condition we're going to talk about is Crouzon syndrome. This is inherited in an autosomal dominant pattern and is the most common syndrome associated with craniosynostosis. This supports the need for children with craniofacial conditions to have a genetic workup. Crouzon syndrome has been implicated with FGFR2 and FGFR3, the fibroblast growth factor receptor, and this plays a role in bone growth, particularly during embryonic development. So this is telling cells to become head, hands, feet, and other tissues. The craniosynostosis seen in Crouzon syndrome involves multiple sutures. Some common head shapes are brachycephaly, scapocephaly, or trigonocephaly. In a severe case with multiple sutures being involved, you can have a cloverleaf skull, also known as Kleeblatt Schädel. Because of the craniosynostosis, increased intracranial pressure is common. Other common features include shallow orbits and ocular proptosis, that's the bulging eyes. Mental deficiency is rare in this patient population. Other findings include maxillary hypoplasia, a narrow palate, and class 3 malocclusion. The treatment for these patients is multiple surgeries. The next related condition is called apron syndrome. This one is also inherited in an autosomal dominant pattern and is very similar to Crouzon syndrome. FGFR2 is the known gene, and the incidence is about 1 in 65,000 to 88,000. The craniosynostosis observed in this condition is described as an acrobrachycephaly, or tower skull, where the coronal suture is fused. A defining feature is the syndactyly seen in the hands and feet, and this is unique to apron syndrome. You'll see in the picture, it's most typically digits 2, 3, and 4, which are fused. Mental disability is common in this patient population. Some common facial features include hypertelorism, that's wide-set eyes, proptosis, the bulging eyes, and down-slanting palpebral fissures. Cleft palate is common, as is a class 3 occlusion, anterior open bite, and V-shaped maxilla. You'll also see delayed dental eruption and crowding, and ear anomalies. Again, the treatment would be multiple surgeries. The next condition we'll talk about is Treacher-Collins syndrome, or mandibular facial dysostosis. This syndrome results from defects of structures derived from the first and second pharyngeal arch. Again, it's autosomal dominant. Incidence is about 1 in 25,000 to 50,000, and it's mapped to chromosome 5q31, the TCOF1 gene. Common facial features include a hypoplastic zygoma. That's where you get the characteristic narrow face, depressed cheeks, and the down-slanting palpebral fissures. They also have a coloboma, which is a hole, and it's a notch in the lower eyelid. Ear anomalies and hearing loss are common. Mandibular hypoplasia is often seen, and a cleft palate is common. Infants may experience respiratory or feeding difficulties due to the airway hypoplasia. And again, the treatment is multiple surgeries. If you've never seen the movie Wonder, this would be a great time to find that movie and go and watch that. It's about a little boy growing up who has Treacher-Collins syndrome and just about his experiences being a kid who looks different than his peers. And then the other picture there, that's Jonah Lancaster from the BBC. So it's really nice to see people out there in the community and promoting just being what it's like to be a person who looks different. The next condition we're going to talk about is craniofacial or hemifacial microsomia. This condition used to be known as hemifacial microsomia because, as you can see in the picture, it looks like only half the face is affected. But on further examination, both sides of the face are affected, just to a different degree on one side versus the other. Thus, craniofacial microsomia is a more correct term for this condition. This is the second most common facial birth defect after cleft lip and palate. It arises from the first and second pharyngeal arches and shares many characteristics with Treacher-Collins syndrome. As you can see, a defining feature is the asymmetrical presentation, where one half of the face is affected to a larger degree than the other half. We're unsure of the exact cause. No specific gene has been identified, but it's thought to usually arise from a spontaneous mutation. The theory is that a vascular deficiency leads to poor blood supply or formation of the fetal face, and this occurs very early on, approximately 4 weeks gestation. Hearing loss is common in this condition. However, there's no mental disabilities. The Omen's classification is a good way to remember what areas of the face are affected. O is orbit, meaning the orbit can either be normal or smaller in size. M for mandible, which could be normal or ranged to an absence of the TNJ and ramus. E for ear. Ear deficiencies could be microtia or no ear canal or preauricular tags. N stands for nerve. There could be no effects or all branches of the facial nerve could be affected. S is for soft tissue, which ranges from no effects to severe soft tissue and muscle hypoplasia. The next condition we'll talk about is Pierre-Robin sequence. Now, this is a sequence, it's not a syndrome. And the sequence indicates that one event leads to a specific presentation. So one thing happens, and then it causes a downstream effect where you find multiple physical findings, and we'll explain this. So Pierre-Robin sequence consists of a specific triad. The triad is micronaphia, that means small jaw, cleft palate, and glossoptosis. Glossoptosis is an airway obstruction caused by a low posterior displacement of the tongue. Now, some syndromes will have Robin sequence as a finding, but it can also occur separate from a syndrome. Now, if you look over here, you can see that embryologic picture that we talked about when we were talking about how the palate forms. So again, this area in the middle is the tongue, and then the PS is the palatal shelf. So what happens in fetal development is the fetal head comes up and then the tongue drops down and these palatal shelves close. Now, in Pierre-Robin sequence, for whatever reason, the head isn't able to come up and the tongue isn't able to drop down out of the way. Thus, you end up with a glossoptosis and also the cleft palate because the shelves aren't able to close because the tongue remains sitting here in the way. Now, there's a couple theories of what actually happens that prevents that tongue from dropping down. One theory is that interuterine mandibular constraint results in the failure of the tongue to descend. And so that just simply means it's constricted for whatever reason, and the head can't come up and the mandible can't drop down like it's supposed to. So a constriction there would prevent that tongue from dropping down. Another theory could be that for whatever reason, the tongue itself doesn't lower like it should, and that's the primary pathologic event, is that the tongue is the problem, it stays in the way and causes the other downstream effects. Another theory is that neurogenic hypotonia could cause a lack of mandibular movement, and so perhaps it's the hypotonia in the mandible that's the problem, and that's why it doesn't get out of the way. So, for whatever reason, the tongue stays up high and the palatal shelves aren't closing, and we find that triad. So, many of these children will experience respiratory difficulties at birth because you can see in the picture down here, the mandible is posteriorly positioned, which means all the soft tissue collapses into the back of that area, causing a restriction in breathing. Sometimes a tracheostomy is necessary to help these children to breathe. Many of these patients will also have congenital heart defects as another finding. Possible treatments include mandibular distraction, that's surgically moving the mandible forward, or a mandibular advancement,